Hi, welcome. I'd like to do a quick review on some of the cardiac issues that we will cover in this module. I'd like to go over cardiomyopathies and then tetralogy of Fallot. So this diagram, you can see the flow of blood going through the heart, through both the inferior and superior vena cava, down to the right atrium, into the right ventricle, out the pulmonic artery, which artery is going away from the heart. And you can't see, it's going to the lungs over here. And then it's coming back through the pulmonic veins into the left atrium, into the left ventricle, out the aorta, and to the rest of the body. In somebody that has a cardiomyopathy, they're going to have problems with the heart pumping blood out of the heart, okay? So we can have either a diastolic dysfunction, which diastolic is in the resting phase where the heart is filling. So it's a filling problem. Or it can be a systolic dysfunction where it is a contracting problem, where the heart is having trouble pushing blood or ejecting blood out of the heart into the body. And some of the types of cardiomyopathies include hypertrophic, dilated, or restrictive. And we'll go into more detail with each one. So the first one we're looking at is the hypertrophic cardiomyopathy. First, we need an understanding on how the normal muscles work. There's normal actin, myosin, and sarcomeres that are passing each other, as in this diagram, for a contraction to occur. So in somebody with hypertrophic cardiomyopathy, these myosin fibrils are abnormally shaped and they kind of bunch together. So it makes this whole muscle end up becoming much thicker. So here's another picture of what's going on with hypertrophic cardiomyopathy. We have the regular heart right here, and we have a hypertrophic heart right here. And as you can see, this septal wall is abnormally thick. So hypertrophic cardiomyopathy is often a genetic problem that leads to abnormal thickening of the muscle. And because it's so much thicker, there is less of a filling space inside the ventricles. So this area is smaller than in our normal ventricle over here. As a result, blood cannot flow into the left ventricle as easily, and therefore it can also not eject as much blood out of the heart to the rest of the body. You'll also notice that this exit route to the aorta is narrower in a hypertrophic cardiomyopathy patient than it is in our normal heart. So we're going to have backing up of blood, backing it up into the left atria. And you can see this left atria is starting to get balloon out, dilate out. And that can cause electrical problems like AFib as a result. And then it'll eventually back up all the way to where there are lungs, so we can have shortness of breath as a result. So here's another diagram showing our normal heart, the hypertrophic cardiomyopathy that we just looked at. Now we're going to look at dilated cardiomyopathy. So you'll notice this ventricular space is huge. So it's not a filling problem. We have no problem filling up this ventricle. So it is not a diastolic dysfunction. It is a systolic dysfunction because this muscle right here is thinner and stretched out, and it can become weaker and not contract as strongly as the normal heart can. So we call this a systolic heart failure. Okay, and then we have a situation where we might have a restrictive cardiomyopathy, where the heart muscle is scarred for some reason or another, and it is not able to fill as much as the normal ventricle. So this is also a diastolic heart failure. So that's a quick summary of the different types of heart failures you might encounter and the differences between systolic and diastolic heart failure. So once again, here's the normal flow of the heart through the blood vessels, the blood through the heart. And now we're going to take a look at tetralogy of Fallot and what's going on there. So this happens in infants, and they have a heart condition that it's tetralogy, so tetra means four, where they have multiple heart problems that lead to poor oxygenation. So we're going to take a look at the abnormal heart for an infant that has tetralogy of Fallot. So here, the issue is we have blood that's coming in on the right side of the heart, and there is some kind of hole or damage to the septal wall. So a ventricular septal defect is occurring. And so deoxygenated blood is mixing with the oxygenated blood and going out the aorta. So that's problem number one. Problem number two is the fact that we have pulmonary stenosis, pulmonary artery stenosis, or pulmonic valve stenosis. So blood that is supposed to lead out of the right ventricle and out to the lungs, it's not getting out there easily because this is stenosed. And the heart on the right side has to work that much harder. So it's going to get larger, and we're going to have a larger right ventricle as a result. The muscle wall, it'll hypertrophy. And then the last issue is this aortic vessel and is shifted over. It's an overriding aorta. So it's kind of midline rather than mostly on the left side here. And so we get more mixing of that deoxygenated blood, and that's going to lead our baby to have blue mucous membranes, signs of cyanosis, things like that, trouble feeding because it can't get enough oxygen because it's getting deoxygenated blood mixing so much with the oxygenated blood, and they're just not having as much oxygenation on their hemoglobin.